So, rheumatic fever. Rheumatic fever is an inflammatory disease that occurs after 2 4 weeks from an infection by group A beta hemolytic streptococcus. It's the only rheumatologic disease in which the link with a single infective causative agent is clear. So, only here there is a clear infective agent, causative infective agent. It was fairly common amongst children in developed countries until the middle of the 20th century. It used to be a major cause of death in children until 1960 and a common cause of chronic structural heart disease. In developing countries, rheumatic fever remains a major cause of death and heart disease. In rheumatic fever, there is a joint involvement associated to several other inflammatory responses, in particular an involvement of the heart valves, most commonly the mitral valve. Surely the pathogenesis starts from an infection with Streptococcus. This microbe has been around for a very long time and somehow we have co-evolved with Streptococcus. We have co-evolved so much that Streptococcus is pretty similar to us. Possibly the general idea is that if you were a Streptococcus, it would be an intelligent thing to try to look as similar to the heart or to the brain of your host as possible, because of course this restricts the possibility that you trigger an inflammatory response against yourself. In some cases, however, the Streptococcus, like in the case of the group A, have done some mistakes. It often happens that we start a response that is extremely good at clearing the Streptococcus, but then this response is maintained active because of the fact that there are common constituents, antigens, that we share with the Streptococcus. These are constituents of the extracellular matrix of the connective tissue that are expressed at the level of the heart, brain and skin, and they keep pushing the inflammatory response. Generally speaking, there is a remodeling of the tissue, which is degraded and then substituted by fibrotic tissue. There is the formation of necrotizing granulomas and small vessel vasculitis because of autoantibodies production. Sub-Saharan Africa has the highest estimated prevalence of rheumatic heart disease. The incidence is highest in school-aged children. Rheumatic disease is a recurrent disease. Very seldom there is a pathogenic involvement of the heart at the first episode of rheumatic fever. But if you keep having a recurrence, the risk of cardiac involvement increases dramatically. There is an important genetic background, even though it is difficult to pinpoint the gene of the rheumatic fever. Again, possibly you need several of them going together. Um, Regarding acute rheumatic fever valvulitis, a combined humoral and cell-mediated immune response to the bacterium may lead to infiltration of the heart valve endothelium by T cells cross-reactive with streptococcal and protein and cardiac myosin. Just remember that we have probably both antibodies associated to the vasculitis itself and T cells that are mostly associated with the formation of granulomas. Diagnosis is based on Jones criteria. You have to satisfy the major criteria and a minor one. We have a typical migratory arthritis affecting large joints. We have in the heart valvulitis and also granulomas, the ash of bodies. In the skin we have subcutaneous nodules with a histology pretty similar to that of cardiac ash of granulomas. Erythema marginatum is also typical. It is so called because it heals in the middle. Chorea, you can have also choreic manifestations, even if the kid has not had a clinically clear-cut arthritis. So, this some vitus dens, that is the chorea, usually develops for 6 weeks after pharyngitis. 10-30% of patients can also present without arthritis. Once you reach a diagnosis during the acute event, you treat the patient with anti-inflammatory drugs to cope with arthritis. But the real danger for rheumatic fever is the recurrence of the attacks, so the only thing that you can reasonably do is to treat patients after an acute rheumatic fever with antibiotics once every month. Antibiotics of choice are penicillins. When you start an antibiotic prophylaxis, this should be continued for at least 5 years or until the age of 21, whichever is longer. Antibiotic prophylaxis should be for 10 years for rheumatic fever with carditis but not valvular involvement, or while into adulthood around 40 years old, whichever is longer. However, with severe valvular damage or with cardiac valvular surgery, then prophylaxis should be continued for life. We give antibiotics only once a month because it has been demonstrated that in order to develop the disease, bacteria must reach a certain threshold number, and by clearing the population out once a month, you are able to prevent them from reaching such threshold. This allows easier regimens and fewer complications from the prophylaxis.